I'd like to welcome everyone to this evening's presentation, Introduction to Health Disparities in the LGBTQ plus community. I'm very honored to have with us this evening, Ashley Purper. Ashley is a community cancer control specialist with the Rutgers Cancer Institute of New Jersey. As part of the community outreach and engagement team, she is responsible for educating the community on various cancer prevention and screening topics through workshops and other outreach opportunities. Ashley obtained her Bachelor of Science in Biology from Westchester University and began working with the Cancer Institute after obtaining her Master of Public Health degree in 2021. So I'm very honored to have Ashley, and I'm going to turn the program over to her right now.
Great, thank you so much. And I just want to confirm you can see the screen?
Yes, I can.
Yes, okay. My little outline didn't come up like it usually does, but as long as you can see it, that works for me. So thank you for having me. Again, my name is Ashley Purper. I use she, her pronouns. I am a community cancer control specialist with Rutgers Cancer Institute. And today we are just going to talk a little bit about health disparities in the LGBTQ plus community. So just a quick reminder before I get started that this really is, a safe space, is a judgment-free space intended for learning and growth. If anyone jumps on, feel free to put your questions in the chat box at any time. We will get to them at the end of the presentation. My email is also up on the screen, so if you have any questions after we conclude the workshop, feel free to shoot me an email and I will get back to you as soon as I can. Also, a quick disclaimer that this information is for educational purposes only and is not a substitute for any type of medical consultation. So the workshops the objectives we are going to cover in today's workshop, we are going to define the LGBTQ plus acronym and some other terminology and concepts. We are going to talk about some health disparities and barriers to care within the community. And then we are going to have a short discussion on local, state, and national resources that people can utilize. And I do always like to do what I call knowledge check-ins. They are true/false statements that I give at the beginning of a workshop and again at the end, and that is when we will actually go over the answers. So I know this is being recorded, so if you are watching at a later time, feel free to pause, read the statements, write down, type out whether you think the answers are true or false. And again, we will cover this again at the end. So the first statement, the LGBTQ plus acronym stands for lesbian, gay, bisexual, transgender, and queer. Statement 2, HPV, the human papillomavirus, is known to cause cancer. 3, LGBTQ plus populations have high rates of tobacco, alcohol, and other drug use. And statement 4, all transgender people are gay. Again, these are true/false statements that we will chat about at the end. So first, we are going to cover some terminology within the community, just so we all have a baseline understanding, which will help us understand the disparities and barriers to care. So firstly, we are going to talk about the LGBTQ plus acronym, what it means. So briefly, it stands for lesbian, gay, bisexual, transgender, and queer. And we are going to talk about these terms a little bit more in depth over the next few slides. So the first letter of the acronym is the letter L, which stands for lesbian. The term lesbian is used to describe a person who identifies as a woman, being romantically or sexually attracted to other people who identify as women. The second letter of the acronym is the letter G, which stands for gay. The term gay is used to describe someone who is attracted to members of the same gender as their own. Most of the time, the word gay is used to describe men who are attracted to other men, but it can also be used to describe women who are attracted to other women. The third letter in the acronym is the letter B, which stands for bisexual. Now, I like to use this example of how language can change and evolve over time. Originally, the term bisexual just meant someone who is attracted to both men and women. But we are starting to move away from really focusing strictly on that binary of men and women. So now the term bisexual is used to describe someone who is attracted to multiple genders. So they're attracted to people of their own gender as well as other genders. And this attraction doesn't need to be, a 50-50 split to be considered bisexual. It doesn't really work that way. If someone finds themselves attracted to members of the same gender as themselves, as well as other genders, then they may be identifying as bisexual. The fourth letter in the acronym is the letter T, which stands for transgender, or trans is the shorthand. The term transgender describes someone who does not identify with the sex they were assigned at birth. For example, a transgender woman is someone who was assigned male at birth and identifies as female. On the other hand, a transgender man is someone who was assigned female at birth and identifies as male. One thing I want to point out when it comes to the trans community is that people may decide to transition in different ways. This can include medically, where they may start taking hormones or undergo certain medical procedures. They may transition socially, where they ask people to use a certain name or pronoun. Or they may even transition legally, where they legally change their name and gender marker on their legal documents. Some people decide to transition in all three ways. Others should choose to transition one way and not the other two. It looks different on everyone, and that's the point I really want to get across, that there's no right or wrong way to transition. I briefly want to go over the correct terminology when it comes to names. Some transgender people might go by what is called a chosen name, which is often different from their legal name. It's important not to refer to their legal name as their real name, because it implies that trans people are playing a character. You want to call them by their chosen name and only refer to their legal name as their legal name if you're in a situation that calls for that. You're filling out some type of legal documentation. For example, if you have a transgender friend named Nicholas and the name on his legal document says Michelle, it is not appropriate for you to refer to the name Michelle as his real name, nor for you to call him Michelle. You would call him by his chosen name, which is Nicholas. The fifth letter in the acronym is the letter Q, which stands for queer. The term queer is used to refer to anyone who is not straight or not cisgender. I did just briefly talk about the term transgender. So the correct term for someone who is not transgender is cisgender. This is someone who does identify with the sex they were assigned at birth. For example, my name is Ashley. When I was born, the doctor said, "It's a girl," and wrote female on my birth certificate. I also identify as female, so I am a cisgender woman. I know the term queer might sound controversial to some people. It has been used as a slur throughout history, but many people have been working to reclaim the term queer and now use it as a catch-all term to, categorize anyone who is a member of the LGBTQ+ community. In some cases, people may use the term queer interchangeably with the acronym LGBTQ, which you might hear me say a few times throughout the presentation. You may not know all the terms. That's okay. LGBTQ+ people use a variety of terms to describe their identity and to talk about who they are. Listen, pay attention to how people are talking about themselves and then mirror their language. The most important thing is really just to respect that self-identification. In most cases, people do write out the LGBTQ acronym with a little plus sign at the end. So the plus sign can represent any other sexual or gender identity that is not included in that LG, B, or T. Some examples of identities that the plus can represent include intersex, which refers to someone whose reproductive or sexual anatomy doesn't neatly fit into the categories of being male or female. The more outdated term for someone who is intersex was hermaphrodite, but now the more current appropriate term is intersex. Some other identities, pansexual, asexual, genderqueer, pangender, omnisexual. There's over 100 different terms that people use to describe themselves. Again, you don't need to memorize them. I'm also not going to dive too deeply into these because we could be here for probably the next 3 days to really talk about all of these in depth. But again, it's really just important to respect that self-identification. And when someone tells you who they are, just listen. So now we're going to spend a little time focusing on the difference between sex assigned at birth, gender, and sexual orientation. So what is the difference? It's important to understand the difference between all of these. So to start off, Your sex assigned at birth refers to the label that your doctor gives you when you are born, solely based on medical anatomy factors. If your doctor writes M for male on your birth certificate, that means you were assigned male at birth. If they write F for female, that means you were assigned female at birth. On the other hand, gender refers to your innermost concept of self as a man, a woman, a blend or combination of both, or in some cases, neither. Your gender identity may be the same as your sex assigned at birth, or it may be different. For example, if you were assigned male at birth and you identify as a woman, your gender identity might be a transgender woman, and your sex assigned at birth is male. Keep in mind, gender identity is an adjective and not a noun. For example, when it comes to the transgender community, you would say transgender or trans person or people. You would not say, oh, a group of transgenders or that person transgendered last year. That's not the proper usage of the language. You would really use it as the adjective. And last but not least, sexual orientation refers to who you are attracted to. Some of the terms I mentioned before, lesbian, gay, bisexual, these all refer to a person's sexual orientation. This can change throughout the course of one's life. Again, it's really important to just respect that self-identification. Another thing I want to point out is, knowing someone's gender identity does not tell you anything about their sexual orientation and vice versa. These are really two separate concepts of identity. So now that we all have a little bit of better understanding of some terminology, we are going to review some common health disparities faced by the LGBTQ+ community. But first, I want to define what a health disparity is. So Healthy People 2020 defines a health disparity as a particular type of health difference that is closely linked with social, economic, and/or environmental disadvantage. Health disparities adversely affect groups of people who have experienced greater obstacles to health based on their racial or ethnic group, religion, socioeconomic status, gender, age, really any other characteristic historically linked to discrimination. A little bit easier of a definition, the CDC defines a health disparity as a preventable difference in the burden of disease, injury, and violence. So on the screen, you will see some of the most common disparities faced by the LGBTQ+ population. LGBTQ youth are 2 to 3 times more likely to attempt suicide. LGBTQ+ youth are more likely to be homeless. Lesbians are less likely to get preventative services for cancer. Gay men are at a higher risk of HIV and other STDs, especially among communities of color. Lesbian and bisexual women are more likely to be overweight or obese. Transgender individuals have a high prevalence of HIV and other STDs. LGBTQ+ populations have the highest rates of tobacco, alcohol, and other drug use. There's also high rates of violence against the community. I know these facts may seem a bit jarring to some of you, so I want to briefly discuss the reason why some of these differences exist. There's often discrimination from family, peers, the medical community, and other services. There's oftentimes a lack of health insurance. There's low levels of cultural competency from healthcare providers. There's a lack of appropriate social services and programs tailored to the community. There's often bullying in schools and a lack of laws that prevents this bullying. There's a lack of safe social spaces. There's been targeted marketing of harmful products, for example, from the tobacco industry, which we will actually talk about a little bit more on the next slide. And there's also an inconsistent collection of SOGI data, which is that sexual orientation, gender identity data in surveys and health records, which makes understanding these disparities a little bit harder. So now we're going to dive a little deeper into some of the disparities I mentioned previously. So let's start with smoking and tobacco use. 20.5% of LGBTQ+ community members partake in the use of tobacco products. Lesbian, gay, and bisexual adults are more likely to use cigarettes and twice as likely to use e-cigarettes. Transgender adults have higher odds of using cigarettes, e-cigarettes, hookah, and cigars. And in addition to using tobacco products at higher rates, youth sexual minorities were more likely to use tobacco more heavily. Research documenting the health disparities among LGBTQ+ individuals is growing, but there is still pretty limited national data available regarding tobacco use among the community. The most current large-scale national data for LGBTQ youth and adult tobacco use rates are from 2016. So there's really that urgent need to improve research in the community. There has been some sporadic data coming out from 2020 and 2021, but again, nothing on a large national scale. But all the data that is available indicates that LGBTQ plus community members are disproportionately impacted by tobacco. But why? Why does this happen? Well, for one thing, tobacco companies use a multitude of methods to target the LGBTQ plus community, including advertising in gay press publications, showing tobacco use as a normal part of the LGBTQ lifestyle. They use corporate philanthropy as evidence of their support. They participate in giveaways, they increase advertising, they host community outreach efforts, that feature specific cigarette brands. And from what we've seen so far, e-cigarette and vaping companies have really followed suit and have really tried to capitalize on this advertising. Some studies also show that LGBTQ plus individuals turn to tobacco more heavily as sort of a coping mechanism due to the added stress of being part of a marginalized population. And why is this important? Well, as I'm sure many of us know, smoking can lead to immediate and chronic health conditions, including lung cancer. If you currently smoke or know someone who smokes or uses vapes or other tobacco products, I will provide some resources at the end of the presentation that can help you or your friend, family member, etc. quit. Now, next I want to look at HIV in the LGBTQ plus community. According to the CDC, in 2018, gay and bisexual men accounted for 69% of all new HIV diagnoses. 1 in 6 gay and bisexual men will be diagnosed with HIV in their lifetime. For Latino and Black men who have sex with men, the rates are 1 in 4 and 1 in 2, respectively. One international analysis found that transgender women in certain communities have 49 times the odds of living with HIV than the general population. So HIV, the human immunodeficiency virus, is a virus that attacks cells that help the body fight infection, which makes a person more vulnerable to other infections and diseases. It is spread by contact with certain bodily fluids of a person with HIV, most commonly during unprotected sex or through sharing injection drug equipment. If left untreated, HIV can lead to the disease AIDS. HIV can affect anyone regardless of sexual orientation, race, ethnicity, gender, age, location. However, certain groups of people in the US are more likely to get HIV than others because of particular factors, including the communities in which they live, what subpopulations they belong to, and their risk behaviors. Risk behaviors do include sexual behaviors and IV drug use. As I mentioned previously, LGBTQ plus individuals are more likely to partake in IV drug use, thus putting them at a greater risk of HIV infection. LGBTQ plus individuals are also less likely to receive preventative care, thus making it less likely for them to receive proper HIV education, HIV prevention medications, etc. Another major disparity we see in the queer community is a high burden of HPV infection. An estimated 61% of HIV negative and 93% of HIV positive gay and bisexual men have anal HPV infections, compared to 50% or less of heterosexual men. Only about 25% of gay and bisexual men are knowledgeable about the relationship between HPV infection and anal cancer. Queer women are less likely to visit and utilize preventative health services, making them less informed about HPV, maybe less likely to receive the proper preventative care. So the human papillomavirus is the most commonly transmitted STI. It is a viral infection. Some HPV infections do clear up on their own. Some other strains may lead to the growth of warts and other conditions. If left untreated, certain strains can lead to the development of cancer. Genital HPV is transmitted by skin-to-skin contact. Its risk is present in all people who engage in sexual activity. Transmission occurs more easily in the presence of irritated skin, as often occurs with penetrative sex. For persons with poor immune system function, infection from HPV may quickly progress to severe illness or cancer. For this reason, HIV positive gay or bisexual men have higher levels of both HPV infection and HPV related diseases than straight men. Women who have sex with women can contract the virus from an infected partner in the same ways that straight women can, including genital to genital contact, sharing of toys without cleaning them properly first. Some people who identify as lesbian have also experienced heterosexual intercourse, which increases their risk for HPV. However, queer women are less likely to regularly visit a reproductive health specialist, the OBGYN, because they feel they are not at risk for contracting STDs, STIs. They're also less exposed to information about HPV or make use of the preventative steps. So HPV can lead to several different types of cancer, and the LGBTQ+ community is disproportionately affected by cervical, anal, and oral cancers. Many queer women delay or forego proper preventative care and screening because they just believe they are not at risk for developing STIs, HPV. And again, women who have sex with women can contract these viruses from an infected partner in the same ways that straight women can. Men who have sex with men are also at an increased risk for anal cancer when compared to the general population. Since the HPV virus is easily transmitted through the skin mucosal contact, oral sex is a potential vehicle for transmission. HPV seems to play an independent role in the development of almost 30% of oral cancers. LGBTQ+ individuals are at a higher risk for HPV infection, thus making them at a higher risk for developing certain cancers. So what can we do? Well, there is an approved vaccine that can start as young as 9 years old that can help prevent certain strains of HPV, thus preventing certain strains of cancer from developing. So now I want to talk a little bit about cancer. I am from the Cancer Institute. So I want to point out there is no biological reason for LGBTQ+ people to develop cancer at higher rates, but there are social barriers and other social factors that can contribute to the queer population being diagnosed at higher rates and at later stages of disease. This is a common theme we see in many chronic diseases, not just cancer, but again, being from the Cancer Institute, cancer is kind of our focus. I also want to point out that disparities exist not only in rates and stages of diagnosis, but also in treatment, recovery, and survivorship. So queer women do have higher rates of obesity, higher rates of smoking. They are less likely to have biological children, or they have biological children at a later age, meaning there's lower rates of breastfeeding. There's also lower rates of proper screening, which are all risk factors for developing breast cancer. So we can deduce that lesbian and bisexual women are at a greater risk for developing breast cancer. And gay men with prostate cancer have some additional social and sexual challenges that are rarely addressed adequately by their oncologists and social workers. Prostate cancer is one of the most common cancers in men in general, or in people with prostates in general, but how men who have sex with men have greater challenges during and post-treatment than the general male population. Again, there is no increased risk for prostate cancer due to sexual orientation, but men who have sex with men are more negatively impacted by the side effects, including issues with sexual intimacy post-diagnosis and post-treatment. And there are very few resources to help these men overcome the challenges. The transgender population is also at a greater risk for not only developing cancer, but facing many challenges in receiving proper treatment from diagnosis onward, along with having high rates of smoking, drinking, drug use, like we spoke about, high rates of HIV, leading to a greater chance of cancer and other chronic disease. Transgender people have extremely low rates of proper screening and overall preventative care, leading to diagnoses at a later stage, if at all. This can be due to fear, discrimination, lack of social services, numerous other social factors. It has also been noted that some transgender people feel very disconnected from certain parts of their body. And I want to note that this disconnect can be extremely severe. This gender dysphoria will cause great psychological distress for some people. For example, a transgender man, someone who was assigned female at birth, may not seek appropriate gynecological services if they still have a cervix. Or a transgender woman, someone who was assigned male at birth, may not seek those prostate cancer screenings, etc., because these parts of their body cause a great distress, this dysphoria, and it's something they don't want to address. So as healthcare providers need to be aware of these additional challenges. So LGBTQ+ people face many factors that contribute to these health disparities. They face many barriers to care. There are many factors that contribute to these health disparities that are as highlighted in this circle picture graphic. Queer populations do have higher rates of homelessness, lower rates of health insurance. As I mentioned a few times, LGBTQ plus populations have higher rates of smoking, IV drug use, alcohol use. A lot of these barriers are due to the added stress and coping mechanisms that go along with being considered a minority population, such as discrimination, prejudice, stigma from peers, family members, and just the overall community. One major contributing factor is potential discrimination in the healthcare setting. It has been noted that many LGBTQ plus individuals delay or forego going to the doctor due to fear of discrimination or just a lack of culturally competent providers. Delaying or not seeking preventative care can lead to undiagnosed disease or receiving a diagnosis at a later stage of disease where it becomes much harder to treat. According to the National LGBT Cancer Network, approximately 60% of oncologists feel they do not know enough to properly treat lesbian, gay, and bisexual patients, while 80% feel they do not know enough to properly treat transgender patients. All of these factors combined with an overall lack of research and data leads to a high disease burden, including HIV, HPV, and cancer in the LGBTQ plus population. Now I do have a quick video I would like to share. I like this because it does highlight some of the things that people within the community as well as their family members may experience when seeking healthcare. And I also think people internalize information a little bit better when they hear some firsthand experiences. So I'm going to play the video. Just let me know if you cannot hear it, but I believe I shared my sound.
To treat me, you have to know who I am.
Not sure why it paused, but we'll try again.
To treat me, you have to know who I am. I identify as the Latina lesbian mother.
To treat me, you have to know who I am. I identify as a transgender man.
To treat me, you have to know who I am. I identify as a gay man.
When I was about 15 years old, I remember going into the doctor's office, and I remember telling her when she asked about my sexual activity if if I use condoms or anything like that, and I said, no, I'm gay. And I just remember her face changed very much, and her warm tone of voice turned very harsh, and it seemed as though she was rushing me out as quickly as possible.
I do think the LGBT community has special needs. I think the LGBT community has a specific special need, which is to be treated the way non-LGBT people have been treated forever, which is to be asked about their sexuality, to be asked about their quality of life, what their home situation is, what their work situation is, what their friend situation is, without the person asking the questions being afraid of what the answers might be.
My partner and I and our children were on a family vacation, and my older daughter became sick. And we get to the hospital, and they asked who was my daughter's parents, and I said, well, she has two moms. And they were like, well, she can't have two moms, only one of you can go in. My daughter was traumatized by that. We were traumatized by that.
My partner was hospitalized recently. When he was being moved from intensive care to a hospital bed, the nurse in charge would not let me accompany him. I asked if I would have been allowed to accompany him if I were part of his family, and she looked the other way.
What needs to happen when a patient is admitted to a hospital is that the care providers think about the fact that the patient might have a different sexual orientation or different gender identity than the care provider.
The people who were dealing with me throughout my pregnancy, primarily my midwife and the nurses associated with them, were not responsive to my identity and didn't actually respect it.
When I was diagnosed with breast cancer, I found that my breast surgeon was unable to call me even to give me my biopsy results. He did tell me very frankly and overtly that he had problems with my transgender status, and upon meeting me and learning of my transgender status, he decided that his first impulse was to refer me to psychiatry.
It's not about sensitivity, it's about respect, it's about humanitarian response to a human being in general.
To treat me, you have to know who I am. I identify as a lesbian.
To treat me, you have to know who I am. I identify as a genderqueer, biracial, Latino parent.
Again, I do like to just show that video because I think it helps people to understand when they hear more firsthand experiences. So I do understand that that was a lot of information and a lot of it can seem very discouraging. However, there are resources all across New Jersey, and I do want to briefly discuss some resources for tobacco cessation, preventative care, and just general information on the next few slides. First, tobacco cessation. As we spoke about previously, LGBTQ+ individuals use tobacco at higher rates and more heavily due to targeted advertising, societal pressures, stress, etc. All of the services you see on the screen are completely free. So the National Cancer Institute, smokefree.gov, they have an LGBTQ+ specific site. They offer some free resources for quitting. They do have an app that is available. The New Jersey Quit Lines, New Jersey Quit Centers, again, completely free, located all across the state. This is also a great time to mention a great resources by Inspira. The Inspira Quit Center offers a welcoming, supportive, and safe environment for everyone. So they do have a free statewide LGBTQ+ quit group that is virtual. So wherever you are in the state, you are able to utilize these services. Looks like they meet Monday evenings. The contact information is here on the screen. So if you're watching this at a later time, feel free to pause, write down some of the information. But again, free, statewide, very inclusive. Also, as I mentioned before, LGBTQ+ individuals are less likely to seek proper preventative care. This is partly because of a fear of discrimination or a lack of culturally competent providers. On the screen, there are a few relatively local resources. We have the Proud Gender Center of New Jersey. This is located in New Brunswick. They offer primary care and a bunch of other services. There is also the Babs Sipperstein Proud Center in Somerville, New Jersey. Again, they offer primary care as well as HIV services and other LGBTQ+ specific services. If neither of these locations are close to you, there is a resource called OutCare. It is an international directory of LGBTQ+ affirming providers. So you would just type in your location, what type of provider you're looking for, and it'll show you those providers near you that are affirming and inclusive of everyone. On the screen, you'll see a few other local, state, and national resources. And we have PFLAG, the Pride Center of New Jersey, Garden State Equality. They offer various services, including advocacy and support groups. Out in Jersey is another large community portal that can provide individuals with, it's almost another large directory, but it's not specific to just healthcare. They have other various resources for the queer community, including primary care, but they also have another great directory of other services that you may need. The National LGBT Cancer Network is a great hub of information for those affected by cancer in any way. They aim to improve the lives of cancer survivors by way of education, training, and advocacy. They also have resources and information for caregivers. And we have made it back to everyone's favorite part of a presentation, the knowledge check-in. These are the same true false statements as at the beginning, so I will just leave them up here for a few moments. Again, if you're watching this at a later time, feel free to pause, write down your answers, compare your answers to your first set, see if you may have learned anything over the course of the presentation. So the first statement here, true or false, the LGBTQ+ acronym stands for lesbian, gay, bisexual, transgender, and queer. This is true. Statement 2, HPV, the human papillomavirus, is known to cause cancer. Again, this is true. While some strains do clear up on their own, some strains do lead to the development of certain cancers. Statement 3, LGBTQ+ populations have high rates of tobacco, alcohol, and other drug use. Again, this is true. And the last statement, all transgender people are gay. This is false. As I mentioned, your gender identity and your sexual orientation are two separate parts of your identity. So your gender identity does not tell you anything about your sexual orientation. You know, you can be transgender and gay, transgender and straight, transgender and bisexual. You could be cisgender and straight. You know, they're just two separate concepts of identity. That does bring us to the end of this presentation. If you are able, we do have an evaluation survey that I would love for you to fill out. It would only take maybe 2 minutes tops. It really just helps me improve my programs and helps the Cancer Institute as a whole improve their programs going forward. So I'm just going to leave this up here for a few more moments. And if you want any additional information about the Cancer Institute, or if you have any questions on cancer screenings, you can contact, the outreach email here or our website.
Ashley, thank you so much. That was so interesting. And I'd like to remind all of our viewers that this evening's program will be available on the library's health portal at justforthehealthofit.org. It will be ready probably in about a week, and it will also be uploaded to YouTube. And I hope that everyone will join us for our next in this 3-part series on June 8th. We're having a program, Tobacco Use in the LGBTQ+ community, and on June 15th, a program on breast, chest health for the LGBTQ+ community. So I hope you will join us. And Ashley, thank you so much for your time. I'm sure you'll get lots of views on YouTube. And thank you for realizing how important this issue is as we all celebrate this Pride Month this June. So thank you so much. And,
yes, thank you so much for having me. And I'm excited for our 2 upcoming workshops, which will actually talk more in depth about some of these topics here.
All right, great. Thank you. And good evening, everyone. And thank you for joining us.